second class of the drugs. They are the sulphonylureas. So these are the derivatives of the sulfonamides. So the sulfur drugs derivatives. So those people who are having the sulfur hypersensitivity reactions, so their chances of having the reactions to your sulphonylureas also, like your rash or urticaria or angioneurotic edemas, etc. It's found to reduce the blood glucose levels. So those people who are in the sulfonamides is an antibiotic. They are used in the World War I and the II. So at that time, more the sulfonamides and the penicillin. These two are the only antibiotics available at that time. So those people who are the sulfonamide therapy, so frequently they used to get the hypoglycemia. Can you tell any other antibiotic which causes hypoglycemia in your clinical practice? Which drugs will cause hypoglycemia other than your diabetic drugs? Good. Antimalarials and also quenolines. Quenoline therapy, like your ciprofloxacin, marvofloxacin, naproxen, etc. So there may be a chance of having the hypoglycemia in them. Mechanism of action by laboratories in 46. Currently available agents. These four are the currently available sulphonylureas: glibenclamide, glipizide, glyclazide, and glimepiride. So everyone has its unique activities. So anything great about the glibenclamide? It's a drug of choice. Good. Pregnancy. How? Why? It does not cross the placental barrier when compared to other sulphonylureas. All sulphonylureas will cross the placental barrier and cause hypoglycemia in the fetus, whereas the glibenclamide does not cross the placental barrier, that can be safely used in the pregnancy. What about the glipizide? Shortest acting sulphonylurea, can be safely used in the renal failure. Okay. So glyclazide is a cardiac friendly drug. So the glyclazide is a very favorite molecule for the cardiologist as far as the cardiodiabetes is concerned. Glimepiride, very rapidly acting drug. 24 hours. Duration of the action is 24 hours. And now the most popular. You see any combination of the sulphonylureas, the glimepiride is there. Your Amaryl or Joril or etc. Okay. So this is the mechanism of the action. You have the sulphonylurea receptors. Okay. So GLUT2 receptors are there. So this is the glucose. They bind to the sulphonylurea receptors on the potassium ATP channel of the pancreatic beta cell and close it, leading to the depolarization of the cell, opening up of the voltage dependent calcium channels, and releases the insulin. So once glucose is entered into the beta cell, so obviously it energized, and then calcium channels will be closed, and then the potassium channels will be opened, and then finally already informed glucose insulin is there that has to be released into the portal circulation. So that is how the glucose stimulates your insulin production. So in the same way, the sulphonylureas also, they have the GLUT2 receptors, and this is how they release the insulin. So that is the reason when the fellow is on the sulphonylurea therapy, there are more chances of having the hypoglycemia, provided if they skip the meals. Okay. Whereas the metformin, nothing to do with this drug. It is not an hypoglycemic agent. It is an anti-hyperglycemic agent. That is the reason, even though with euglycemia in young females with PCOD, they use the metformin, because it won't cause any hypoglycemia. But the sulphonylurea, just you give 1.25 mg of your glimepiride, or maybe the 2.5 milligrams of your glipizide. If they skip the food, so definitely these people will going to get hypoglycemia. Very potent drug. Very potent drug. So these are the duration of the actions. Longest acting is the glibenclamide, very popular in rural India by brand name Dionil. Drug half-life is 8 to 12 hours. Duration is beyond 24 hours. The daily dose usually starts at 2.5 mg, but it is available. Dionil 5 mg is available. Semi-Dionil, that is 2.5 mg available, and you can go up to the 10 milligrams to 20 milligrams also. Glipizide, it acts about 8 to 12 hours, not exactly 12 to 14 hours. So it has to be given thrice a day, and the daily dose is about 40 to 320 milligrams. But hardly we use 15 milligrams of the glipizide, and maximum is 30 milligrams we use in the clinical practice. Glycoside 2.5 mg to 20 milligrams. The duration of the action is about 12 hours, so it has to be given BD. Now the sustained release tablations are also available. They can be used as a OD therapy. See the glycoside MR or the XR. And glimepiride, your favorite drug. The duration of the action is nearly 24 hours. And the daily dose is 0.5 milligrams also we use. Semi-amyl, etc. 0.5. So 1 mg is there, 2 mg is there, 3 mg is, 4 mg is also there. 4 mg with the metformin, etc. The good combinations are also there. That is the glimepiride. And the daily dose is 1 to 8. But the take home point here is, in general, the maximum effective dose is 50% of the maximum marketed dose. Okay. Suppose if you want to use the glimepiride, what is the maximum dose? 8 mg. But don't use beyond 4 mg. Because you won't get any benefits as well as the blood glucose reduction is concerned. So use the 50% of the maximum doses in our clinical practice. So if you want to use the maximum doses, go to the another drug. So combination therapy. So 4 milligrams of the glimepiride, you are not happy with the results. Still the blood sugars are very high. So you have the two options. One option is go to the 8 mg of the glimepiride, 4 mg BD, or the second option is add some other drug. So always go for the combination therapy rather than the individual drug by escalating the highest dosages, because you are inviting more and more complications and the side effects. See, it's a potent anti-diabetic drug, sulphonylureas, like your metformin. Metformin reduces HbA1c by 1.5 to 2%. The same reduction also will be seen with the sulphonylureas. So it can reduce the fasting by about 40 to 70 milligrams. The action is immediate, best taken about 30 minutes before the meals. Effectiveness depends on the availability of the sufficient endogenous insulin reserve. So when the fellow is having the more endogenous reserve, so whatever the free-formed insulin is there, when the beta cells are stimulating insulin production, then you will have insulin released into the portal circulation. Suppose if the beta cells are fatigued, there is no beta cell activity at all. So like your type 1 diabetes. So whatever the amount of sulphonylureas you give it, not of much benefit, and you don't get any insulin. So this is the most important take home point. So those people who are having the endogenous insulin production, so you can use the sulphonylureas, otherwise it is not of much use. The same thing happens in the type 2 diabetes also. See, the type 2 diabetes of 40 years duration, or 35 years duration. That means all these 30 years or 35 years, 40 years, the pancreas being bombarded with so many drugs. And finally, no amount of the beta cell is there in the pancreas to produce more and more insulin or to secrete more and more insulin. So at that stage, there is no meaning in continuing the sulphonylureas therapy in such individuals. So type 1 diabetes means no production. So that is common. Insulin is the lifelong. Type 2 diabetes, also chronic type 2 diabetes, definitely they behave like the type 1 diabetes at the latter stages of their life. So that is the reason there is always a role for the insulin in most of the type 2 diabetes when the duration is very high. 20 to 30% of the patients may fail to respond to sulphonylureas even at the first use of the therapy. That is primary failure. So the primary failure is luckily is not that common in Indian patients. Our people, they respond very well in the initial days of your sulphonylurea therapy. But as days goes on, so whatever the amount of the sulphonylurea you use it, still the blood sugars are very high. So that condition is secondary failure. So the primary failure is from the day one, they won't respond. Secondary failure, they respond very nicely in the initial days, and the latter days, because of the beta cell fatigue, so they may not respond you well. So tend to become less effective with the continued use, that is a secondary failure. So fortunately, in India, we are not having much of the primary failure. Most of our people, they respond very well initially. But on the other hand, we are having very high index of secondary failure in our population. So again, as a clinician, as a physician, you should understand the secondary failure. So you must have seen a lot of the patients with the diabetes with the sulphonylurea therapy previously. But still the blood sugars are very high. So then you should understand that this patient could be a case for secondary failure of the sulphonylurea therapy. So then the answer is, don't use the sulphonylureas in them when they are having the secondary failure, and choose other drugs. Otherwise, if you use the same drug, suppose if my prescription contains the glimepiride And if you change to the glycoside, nothing, not much benefit you are going to get it. So if your understanding is it's a secondary failure, stop whatever may be the sulfonylurea the patient is taking, and then choose some other drugs like your metformin or alpha glucosidase or the gliptins or the DP4 inhibitors or the insulins. So these are the contraindications of the sulfonylurea therapy as they are derived from the sulfonamides. So hypersensitivity to the sulfur drugs. Renal insufficiency, in the same way, all the drugs, we have to respect the kidney function. So according to the renal insufficiency, we have to adjust the dosages. See the gliptide up to GFR 30, no dose adjustment, use with the caution when it is less than the 30. So that is the reason it is renal friendly, mostly the renal friendly gliptide. Glycoside up to 330, no dose adjustments, low dose. Glimepiride less than the 60, you have to stop the drug, and glibenclamide to be avoided because prolonged hypoglycemia. So when the people get the hypoglycemia with the glibenclamide, that is a very much prolonged hypoglycemia, and when the fellow is in the CKD, so again the chances of having the hypoglycemia is very, very severe. So in the presence of the renal insufficiency, you have the two options to use the OHS or the sulfonylurea DH. So best option is gliptide, and the next best is glycoside. So hepatic insufficiency, so better to avoid the OHS because the metabolism in the liver only. Pregnancy, we don't use the sulfonylureas, but in Africa they use the glibenclamide. In India, we don't use the glibenclamide in pregnancy. Immediately following the acute coronary event, if you use the sulfonylureas, the chances of hypoglycemia, and hypoglycemia potentiates your tachyarrhythmias, and definitely the patient may die of the arrhythmias. So don't use the sulfonylureas immediately after the acute attack of the coronary events. So type 1 diabetes, all OHS are contraindicated, and DKA or any emergencies, so better to go for the insulin therapy only, no OHS. So these are the contraindications to the sulfonylurea, any OHS. What are the side effects? So they can initiate the insulin secretion independent of the ambient glucose levels. Hence hypoglycemia is a very common side effect. All agents like glibenclamide can produce the prolonged hypos. So hypoglycemia with the glibenclamide, they may last for about 2 days also. So don't discharge the patient immediately after the hypoglycemia correction. Suppose if the patient is found in the hypoglycemic in the casualties or in your emergency wards, suppose the blood sugar is 20, you are given the 20% dextrose. After half an hour, the blood sugar is 250. So don't be happy. Again check the blood sugar after 1 hour. Again it will be 40. And then they give the 25% dextrose, it will be 300 after 1 hour. Again after 1 hour, again the blood sugar is 60. So there will be the much fluctuations in the blood sugars are there. In those people, hypoglycemia due to the glibenclamide therapy. So that is a very important. To minimize the risk of hypoglycemia, start low and step up. So that is very important in any drug, because this is a lifelong disease, it's a progressive disease, and it is a dynamic disease. There is no hurry in treating the hyperglycemia very fast. So always control the blood sugars very effectively without the hypoglycemia risk. So weight gain is a very common in the sulfonylureas because these people will get the hypoglycemia and immediately they eat something. So the calorie intake will be more in those people on the sulfonylurea therapy, and weight gain is very common on sulfonylurea therapy, like your insulin therapy. See, insulin also causes weight gain. Hypersensitivity reactions, rarely the Stevens and Johnson syndrome. So that is your sulfonylureas. Now the non-sulfonylurea secretogogues. Repaglinide and natiglinide. Out of them, the repaglinide is very popular in our Indian market. 0.5 mg and 1 mg. Mostly the postprandial hyperglycemia, just like your oglibose. So, but this is the sulfonylurea, non-sulfonylurea secretogogue. They are the insulin secretogogues, structurally unrelated to your sulfonylureas. Repaglinide belongs to the meglinide group, while the natiglinide is an amino acid derivative. Both drugs share a common point of interaction of the sulfonylurea receptor 1 subunit of the ATP sensitive potassium channel, distinct from the sulfonylurea receptors. So these are the mild agents, short acting. They reduce mostly the postprandial. They don't reduce the fasting hyperglycemia. they reduce the HbA1c by 0.5 to 1%, whereas sulfonylureas, they reduce by 1.5 to 2%. Minimal effects on the fasting, useful in individuals who show the marked postprandial excursions of the glucose while maintaining the normal fasting blood sugar. So the mostly we use it, this repaclinated, we are using it in the Indian market as to reduce the postprandial hypertension. That is the reason O-glucose and repaclinated combination is available in the Indian market. Urepa 0.5, 0.2. So 0.5 is the repaclinide and 0.2 is O-glucose. In the same way, 0.5 and 0.3 is also available combination. So that 0.5 is repaclinide and 0.3 is O-glucose. And 1 plus 0.2 is available, 1 plus 0.3 is available. So repaclinide 0.5 and 1 and the O-glucose 0.2 and 0.3. Useful in individuals who are having the postprandial hyperglycemia. So already told you the dose. Taken before the meals because you have to tackle the postprandial hyperglycemia. So the postprandial hyperglycemia you have to give before the meals. Can be used as the monotherapy or as a combination of the metformin and other OHs. Repaclinide can be used even in the renal failure also because short-acting drug. Now alpha glucosidase inhibitors. So you have the acarbose, you have the miglitol and the O-glucose. Out of them, O-glucose is the most popular now. Earlier acarbose was available. So this is the mechanism of action. So it inhibits the intestinal absorption of the glucose. So whatever the food we eat, if it contains the carbohydrate, so it has to absorb from the intestines. So that intestinal absorption of your carbohydrates will be blocked by these alpha glucosidase inhibitors. So these are breast border cells. You are using the alpha glucosidase, so that inhibits the absorption. See the acarbose and the carbohydrate without acarbose and with acarbose. That yellow one is the without any drug. So there will be postprandial hyperglycemia. See the red one. So the postprandial hyperglycemia will be nullified and there will be a smooth and minimal elevation of your postprandial hyperglycemia with the acarbose. The same thing happens to your O-glucose also. So to reduce the postprandial hyperglycemia, so these drugs will help you. Usual dose acarbose is 50 mg, whereas O-glucose is 0.2 and 0.3. Hypoglycemic potency 50% of the sulfonylurea or the metformin, very low. Side effects mostly the gastrointestinal. It acts only at the intestine level. So gastrointestinal side effects you can have it. Like the flatulence is more with the acarbose, not with the O-glucose. Bloating, yes, with the O-glucose, and abdominal discomfort. So nausea, some vomiting, abdominal discomfort. So flatulence, these are the side effects of this O-glucose and the acarbose. Mostly the intestinal side effects. They are the most useful in patients who consume diet rich in the complex digestible carbohydrates. Our people. So Andhra population. So they're rich with the carbohydrate diet. So they take 2 times or 3 times also the carbohydrates, more rice. So these are the important drugs to be used in them. But only hurdle is it reduces the HbA1c by very low. It reduces only postprandial hyperglycemia. See here 0.5 to 1%. Peak postprandial by 20 to 80. Avoiding patients with chronic intestinal diseases and advanced chronic liver diseases. See, in all the intestinal diseases, don't use it because the action is at the intestinal level, like your inflammatory bowel diseases, like ulcerative colitis or the Crohn's disease or malabsorption syndromes. So better to avoid these drugs. Adverse reactions can be minimized by starting with a low dose and slowly up titrate. So acarbose already told you 50 mg available tablet is available, 25 mg tablet is also available. In the same way, O-glucose 0.2 to 0.3, so twice or thrice a day. To be administered along with the first bite of the food, that is the most important one. Before the food is always advisable. So that finishes our alpha glucosidase inhibitors. Now moving to the thiazolidinediones. You have the 3 types of the thiazolidinediones. One is the trocladazone, the second one is the rosiglitazone, and the third one is the pioglitazone. The first 2 glitazones, they are not available right now. So the only thiazolidinedione available in the market is pioglitazone. So this is the actions. So here the PPR gamma. So the main action is to increase the glucose uptake into the skeletal muscle by increasing the synthesis of GLUT4 and its translocation to the cell surface. So GLUT2 is your sulfonylureas at the beta cell. Here the GLUT4 is with the PPR GLUT4, that is with the pioglitazone or thiazolidinediones. So it improves the insulin sensitivity. It pushes the glucose into the muscle. It pushes the glucose into the adipose tissue. So the peripheral utilization of the glucose will be more with the pioglitazone or your thiazolidinediones. So this is also a drug which can tackle your insulin resistance like your metformin. Metformin 60 to 70% acts at the level of the liver and nearly 20 to 30% acts at the level of the muscle adipose tissue. Whereas here thiazolidinedione like your pioglitazone acts nearly 60 to 70% acts at the level of the muscle and adipose tissue, and 20 to 30% they also act at the level of liver. So the insulin resistance, two drugs we are having. One is metformin, mostly acts on the liver, and pioglitazone or thiazolidinedione mostly acts at the level of the muscle and adipose tissue and also acts at the liver. So this is the thiazolidinedione, glucose GLUT4 receptors and glucose uptake and its utilization, and PPR gamma and PPR alpha were triglycerides. So that is the reason a drug is there which acts both on the PPR gamma and PPR alpha. So that is saroglitazar. So the saroglitazar is a drug which acts both at the PPR alpha and PPR gamma. See the activators of this in the nucleus of the target cells, specifically skeletal myocytes and adipocytes. Enhances the sensitivity of the insulin, so it improves the insulin sensitivity, promotes the adipocyte differentiation, promote the uptake and storage of the free fatty acids, enhances storage of the subcutaneous fat versus the visceral fat, reduces the triglycerides and free fatty acid levels, which reduces insulin resistance and leads to an increase in the glucose uptake, decreases the tumor necrosis factor alpha expression, no increase in the insulin secretion, if anything a slight reduction due to the reduced demand, regresses the progression of the carotid intima-medial thickness. So these are all the advantages of the thiazolidinediones. So it improves the insulin sensitivity. Okay, it is a lipid friendly. It is almost like a cardiac friendly also, but it increases the body weight and it increases the anemia. So that is the reason it is contraindicated in heart failure population. One and all for your patient here.